Thanks so much for the opportunity to present. I'd like to thank Dr. El Mansour and the organizers of the meeting for inviting me to participate in this virtual meeting. So over the next 20 minutes or so, I'm going to talk about aggressive B-cell lymphomas, including double-hit lymphomas in 2022, and what is the ideal regimen and ideal CNS prophylaxis. And I know a lot of the CNS prophylaxis question has already been covered by Dr. Ferreri. Here are my disclosures. So just to start out, in the modern era, approximately 75 to 80% of patients with diffuse large B-cell lymphoma are cured with immunochemotherapy. And we've done a very good job of clinically identifying subsets of patients who will not do as well with standard therapy. So if we use the IPI score, you can divide out patients low risk, intermediate, and high risk, and see that the high risk patients do much worse. We've also made a lot of progress in understanding the molecular biology of diffuse large B-cell lymphoma. And though there's some controversy, patients who have the ABC subtype have typically had a worse outcome compared to those with the GCB subtype. But talking about high-grade B-cell lymphomas, a number of years ago, it was identified that those patients who had a MYC and a BCL2 translocation, so-called double-hit lymphoma, had an inferior outcome compared to patients with de novo diffuse large B-cell lymphoma. And the second curve here is a study from MD Anderson where they showed this. And you can see that the overall and progression-free survival here is much less than the 75% that you typically see with DLBCL NOS. And there have been subsequent studies done that have confirmed this. A very large study on the right at the Lunenburg Consortium, which was led by Dr. Andreas Rosenwald, and showed that those cases with a MYC rearrangement had a significantly inferior outcome. So in terms of understanding double-hit lymphomas and high-grade B-cell lymphomas, approximately 30% of diffuse large B-cell lymphomas have got a BCL2 rearrangement, 10% have got a MYC rearrangement, and about 4% are double-hit lymphomas. And most of these have got a MYC and a BCL2 rearrangement, and they are mostly of GCB origin. Very infrequently, you see triple-hit lymphomas. Those lymphomas that have a BCL6 rearrangement are usually of ABC origin. And if they have all three, they're called triple hit. And this is different to double expressor lymphomas. I think it's really important to point out that double expressor lymphomas in many studies make up about 40% of all diffuse large B-cell lymphomas. These have high BCL2 and high MYC expression. And while there can obviously be overlap with the double hit lymphomas, most double expressor lymphomas are of ABC origin and do not have the hits. So, I think as we are understanding high-grade B-cell lymphomas and where they lie in the spectrum of aggressive B-cell lymphomas, there, really is a spectrum that starts with DLBCL NOS on one end and Burkitt lymphoma on the other end. And then in between those, we have these entities, high-grade B-cell lymphoma with MYC BCL2 and or BCL6 translocations, and then this rare entity, high-grade B-cell lymphoma NOS. And this entity does not include double-hit lymphomas, but it can include lymphomas with a MYC rearrangement or a BCL2 rearrangement, or they might not have these. They might just have high proliferation. So this diagnosis is designated by the pathologist based on WHO criteria. And in terms of talking about high-grade B-cell lymphomas and double-hit lymphomas, we continue to better understand the biology of these diseases. And it's not straightforward, and it's a continuously evolving story. These are two pretty recent studies that have evaluated the biology of double-hit and high-grade B-cell lymphomas better. The first of these is from the British Columbia group, led by David Scott's group, and they looked at 157 GCB tumors with DLBCL morphology, and they applied RNA sequencing to these cases. And what they identified was that 27% of them had what they described as a double hit signature. And what was important about this study is that those cases with the double hit signature, about a half of them were double hit lymphomas defined by a MYC and a BCL2 translocation, but about half of them did not have a MYC and a BCL2 translocation. But importantly, they did much worse with standard R-CHOP therapy. The group in the UK did a similar type of study with over 900 cases. They defined a molecular high-grade signature, and again, a significant proportion of these cases were double hit, but a number of them were not, and these cases did much worse when they received R-CHOP therapy. So I think this tells us that there's more to the story than doing FISH to evaluate double hit biology. And while it's important to be able to identify MYC and BCL2 translocations, in terms of really understanding the biology of these tumors, there's more to the story than we can detect by FISH. And that's important clinically because these patients do worse with standard therapies. This is from a recent publication that was led by Lawrence Deval and David Scott. And it really just shows where the understanding of the molecular biology of DLBCL lies. Historically, the disease was divided into ABC and GCB, but with the ability to identify several different mutations, our understanding of these tumors has significantly evolved. And in terms of the high-grade B-cell lymphomas in Dr. Ship's classification, these fell into a cluster 3 group. And as you can see here, they also fall into a group that is GCB derived according to this slide. So what is the optimal approach to high-grade B-cell lymphoma? Should people get R-CHOP? Is a dose intensity approach better? And these are select studies that hopefully help to answer or at least provide some evidence on this topic. The first of these studies was a very large study led by Andreas Rosenwald. They looked at over 2,000 patients with diffuse large B-cell lymphoma. 11% of them had a MYC rearrangement. They evaluated how did those patients with MYC rearrangement do and what associated characteristics were associated with outcome. Having a MYC rearrangement was associated with a shorter PFS and OS, as shown here, and those cases that were double hit versus single hit did much worse. One really interesting finding of their study was that they looked at the MYC partner gene. I should say that all of these patients had diffuse large B-cell lymphoma and were treated with R-CHOP, and they showed that if you had an IG partner versus a non-IG partner, then you had a much worse outcome. So the bottom curves for PFS and OS shown here are the IG partners. There have been 2 prospective studies in high-grade B-cell lymphoma or double-hit lymphomas. The first study was done by us using dose-adjusted EPOCH-R. We did the study in centers around the US, accrued 53 patients, and showed a 4-year event-free and overall survival of 71% and 77%. And there was no difference in outcome for the single-hit versus double-hit patients. In the Netherlands, the Hoven group did a prospective study evaluating R-CHOP plus lenalidomide. Again, it was a prospective single-arm multi-center trial and showed a 2-year EFS and OS of 63% and 73% for cases that had a MYC rearrangement. With respect to dose-adjusted EPOCH-R, I mean, why might that work well in high-grade B-cell lymphomas? So shown on the left is a multi-center study of the regimen in Burkitt lymphoma. There was an initial study done at the NCI with 30 patients, showed a very good response with the regimen in patients with Burkitt. So this led to a multi-center trial of 113 patients, which was published in 2020. And the EFS and OS shown here were over 80%. I think showing that the regimen is highly effective in Burkitt lymphoma. And as you know, as I've said, there really is a lot of biologic overlap between Burkitt and high-grade B-cell lymphomas, and this was the reason for studying the regimen in MYC-rearranged aggressive B-cell lymphomas. And as I said, there was no difference between double hit and single hit. What about other approaches? The last three studies here, the first two included a lot of patients with high-grade B-cell lymphoma, and they investigated strategies other than R-CHOP. So the first study investigated a dose-dense regimen that comprised high-dose methotrexate, CHOEP14, and high-dose RSC. The second study is a British study that looked at R-CODEX-M and or IVAC in patients with high-risk DLBCL, including high-grade B-cell lymphoma. And I think it's important to point out here that these two studies, I mean, they investigated aggressive treatments for high-risk aggressive B-cell lymphomas, but the overall survival and FFS and PFS shown here are very good, and what we see with DLBCL NOS, so not really showing an inferior outcome when these regimens are used. But of course, these are not randomized studies. These are single-arm studies. I think this last study is a French study, and I think that's interesting. It's a retrospective study of 160 patients, and they looked at outcomes for patients who had high-grade B-cell lymphoma, so 160 high-grade B-cell lymphoma cases. They got R-CHOP versus intensive therapy. And at 32 months, the 2 and 4 year PFS for the R-CHOP group were 40% and 28%, and 57 and 52% for the intensive therapy group. Of course, this is retrospective, so these results have to be interpreted in the context of that, but I do think that they are interesting. There are a lot of novel approaches for high-grade B-cell lymphoma, and I'm going to talk a little bit about some results in using CAR T-cell therapy particularly. A lot of these targets that we are targeting in diffuse large B-cell lymphoma NOS are important in high-grade B-cell lymphomas, such as CD19, CAR T-cells, monoclonal antibodies, antibody-drug conjugates. The bispecific antibodies are interesting. There are, of course, direct inhibitors that make a lot of sense, such as targeting MYC, BCL2, EZH2. Some studies looking at the addition of immune checkpoint inhibitors for high-grade B-cell lymphomas. And then, of course, there's a lot of interest in polatuzumab, and there's not, I think, enough evidence at this point to show that it has a preferential benefit in high-grade B-cell lymphomas, but it's going to be very interesting to see exactly the extent of its activity and if there is any differential activity in these different subtypes as we attain more data with the combination of polatuzumab with immunochemotherapy. So I think it's really interesting if we look at the recent anti-CD19 CAR T-cell studies and look at those patients who had high-grade B-cell lymphomas. And we now have enough studies and enough data, I think, to have identified a pretty high number, or a sizable number of high-grade B-cell lymphoma cases in these studies. And again, this is early data and non-comparative for the most part. But the overall response rate and complete response rate for this subset of patients looks like it's particularly good with anti-CD19 CAR T cells. And our experience with treating these patients in the relapse and refractory setting is that they typically have a very, very poor outcome. This is some real-world CAR T cell data. And again, we now have significant numbers of patients with high-grade B-cell lymphoma. And again, the response rates so far look pretty promising. Is there any reason why high-grade B-cell lymphoma might be more sensitive to anti-CD19 therapy or might be more sensitive to CAR T cells? We don't know this, but there have been some mechanisms that have been proposed Perhaps there are some advantages that these tumors have over DLBCL NOS. There may be some mechanisms through PD-1 and LAG-3. They have a reduced microenvironment signature. So some of these might offer advantage in terms of better efficacy of CAR T cells. Dr. Ferrari has done an excellent job of talking about CNS-directed prophylaxis and all of the controversies in that in diffuse large B-cell lymphoma. As he pointed out, in high-grade B-cell lymphoma and in double-hit lymphomas, there has been a very high risk of CNS dissemination in retrospective studies, higher than you would see with DLBCL NOS. But I think really to summarize the area, I think that the majority of these patients it really makes sense to check their CNS pre-treatment with both cytology and flow cytometry. But the role of CNS prophylaxis, just as it is in DLBCL NOS, is unclear. We still really haven't identified who should get it, if they get it, how they should get it. Should they get intravenous or intrathecal methotrexate? Should they get it during treatment or at the end of treatment? And if they're getting any of these particular approaches, how should it be dosed? These are all unanswered questions that hopefully we will be able to answer in the future with well-designed trials. Just on this point, in terms of CNS-directed prophylaxis, these are two interesting studies that were recently published in Blood, one from a US group and one from a British group. I think that, to summarize what they showed, they looked at different ways of giving CNS prophylaxis, and there did not seem to be significant differences in CNS relapse rates, whether you gave intravenous or intrathecal, and whether they were given concurrently or at the end of treatment. And disappointingly, in these studies, the number of patients or the proportion of patients who did get CNS relapse despite prophylaxis was, as you would have predicted from the CNS IPI score. So in aggressive B-cell lymphoma, and in high-grade B-cell lymphoma in particular, how should you think about CNS prophylaxis and which groups should receive it? In my own practice, I use the CNS IPI, and as Dr. Ferrari discussed, there are a number of extranodal sites that have been associated with an increased risk of CNS relapse. So I think for all of these patients, the CNS should be checked at initial diagnosis. Cytology and flow cytometry should be done. There are some challenges with flow cytometry because it does not seem to be the most reproducible assay, and that's a challenge in terms of, I guess, recommending it in every institution. If the CNS is positive, then the patient needs to receive treatment for the CNS, and then if it's negative, I think in these high-risk groups, CNS prophylaxis has to be considered, as Dr. Ferrari has outlined. For the high-grade B-cell lymphomas, I think if we look at Burkitt lymphoma, we almost always give CNS prophylaxis. There is pediatric data in very limited stage Burkitt lymphoma where CNS prophylaxis was not given, and there were excellent outcomes and very low rates of CNS, but that's a minority of patients. And other than that, CNS prophylaxis is typical in Burkitt lymphoma. And I think at this point in time, again, understanding that we do not have enough data to answer this question correctly, I think it's very reasonable to give CNS prophylaxis for a lot of these high-grade B-cell lymphoma cases. But I would say that there is some data with early-stage cases showing that they have an excellent outcome with standard treatment, and a lot of these did not get CNS prophylaxis. So I think certainly for high-grade B-cell lymphoma with high IPI scores and advanced stage of disease, I think it's reasonable to give CNS prophylaxis, but understanding that we do not have enough data at this point in time. The ABC subtype in one of the studies that I showed you was associated with a higher risk of CNS prophylaxis. I think it's something to consider. And I think, again, if a patient has the ABC subtype, and this is in the context of a high IPI score and other risk factors for CNS dissemination, then it should be considered to institute CNS prophylaxis. So in conclusion, high-grade B-cell lymphoma remains a therapeutic challenge. There are poor outcomes compared to DLBCL NOS. There remains controversy as to the optimal frontline approach. I would say that retrospective experiences and very limited prospective data favor dose-intensive approaches. And if you consider the biology of these tumors and their similarity to Burkitt lymphoma, it, I think, makes sense that an approach that's effective in Burkitt lymphoma, in the absence of robust data, might make the most sense in these patients. The problem with a lot of Burkitt type treatments is that they are associated with very high toxicity. So dose-adjusted EPOCH, for example, works in Burkitt, but is not associated with the same degree of toxicity that you see with Codex-M, IVAC, or Hyper-CVAD, or the other typical Burkitt regimens. I think that the data, especially with CAR T cells in relapsed refractory high-grade B-cell lymphoma, is very promising and interesting. We now have some studies incorporating CAR T cells in the upfront setting where they're used after initial immunochemotherapy in patients who have interim assessment and have positive PET scans. So I think it's going to be interesting to see if this group, high-grade B-cell lymphoma, may benefit from, or if some patients may benefit from upfront use of strategies such as CAR T cell or other strategies. So with that, I thank you very much, and I'm happy to take any questions.